Hello people, how are you? In this video, let's look at this topic non-union. So a non-union of what, guys? Of a fracture. Okay. So non-union means what? It is not united, right? So look at this image here. They are showing you the fracture of this, I'm guessing it's a humerus. So here you can see there is no union at all. Okay. There is another terminology called as malunion. Malunion is united but in a wrong way. That is a malunion. But here we are discussing non-union. And non-union means what? It is not united, right? But when do you say it is not united? So as soon as you break your hand and there's a fracture, will you say it's non-union? No, you have to wait for some time, right? So there can be delayed union. Okay. And further, if it doesn't unite, we can call it as a non-union. And there is another terminology called as malunion. So a lot of terminologies in this, we are looking at what? At non-union. Very good. So guys, what have you learned till now? Delayed union. If it is taking more time than required, then it is a delayed union. And if it is not at all uniting, it is a non-union. NU. Okay, non-union. So basically, if the union does not progress and there is a failure to unite, then only it is called as non-union. So how will you say what non-union is? You will say that if there is non-union of a fracture, means if the union does not progress or there is they fail to unite, this is called as non-union. Okay, so it is after 6 months only you can declare it as non-union. Okay, after 6 months you have to wait at least 6 months. After that also so many criteria, then only they are, you should take time, then only you will declare it as non-union. Okay. So you will need some progressive X-rays evaluation to check over time whether it is not at all uniting. Is there no progress at all? So you need to, this word progress is important here. There is no progress, right? So there is you need a progressive evaluation of the X-rays, right? So you cannot just take an X-ray and then declare that it is non-union. You still need to see the progress, right? It is not at all progressing. That's what they are telling here. Okay. So how can you say without X-ray that there is non-union? Possibly there is mobility, right? Abnormal mobility at the fracture after a reasonable period, okay, or if there is pain, all this can indicate to you that there is non-union. Okay, sometimes this can be painless also if there is a pseudo joint formed. That will be like a pseudo arthrosis. But I'm thinking if there is a pseudo joint formed, won't it be more like a malunion? What do you say, people? Okay, painless if pseudo arthrosis. Okay, pseudo joint forms. If a pseudo joint forms, but I am thinking that will be something like a malunion. I wouldn't put that here. What do you say, people? Okay. So anyways, if there is mobility which is abnormal, right, at the fracture, there is mobility. Mobility at fracture. That means it's not united, correct? So this is all about non-union. Now let us look at the causes of non-union. Causes of non-union. Okay. Shall we look at the causes of non-union, guys? So the causes of non-union, they have divided it as the causes related to the patient, the causes related to the fracture itself, and the causes related to the treatment. Okay. After this, we will look at the types of non-union, etc. As of now, what are we looking at? Causes related to patient. See, if the patient is old or if they have some malignancies, osteomalacia, that is bone is so soft, etc. Because of whatever reason, could be vitamin deficiency, vitamin D deficiency, calcium deficiency. So in these people, obviously related to the patient, there can be non-union of the fracture. Now coming to the causes related to the fracture itself. Okay, look at this. Main thing they are telling is immobilization. Okay, the patient is still using and mobilizing it, then it will not heal. Okay, that is the main thing. Non-union. Non-union, mainly they are blaming, what am I saying? Immobilization. You're not enough immobilization. So you have to, should not move it much. Okay, give it chance to unite. Distraction at the fracture site. Muscles pulling the fragments, like of the patella, right? There is a muscle pulling the patella. You know that the rectus femoris, is it? It pulls the patella, and there is a patellar ligament at the bottom of patella, right? If I'm not wrong, if this is patella, here you have a muscle and here you have a ligament. So these are pulling the fragments, right? Fracture olecranon. So is something attached to the olecranon process. Then coming to gravity, fracture of shaft of humerus. Just see how the humerus has to work against gravity, right? So whereas this looks more like a radius ulna fracture or something. Okay, leave that. So if this is humerus here of this boy, it's always against gravity, right? Unless he's sleeping. Then soft tissue interposition. Fracture of shaft of humerus, same thing. Humerus, shaft of humerus they're talking about. So here if you have humerus, let me draw humerus here. This is our humerus. So shaft of humerus is fractured, they are saying. So what will happen? Soft tissue interposition, fracture shaft of femur. So again here femur. If femur shafter is fractured, medial malleolus. What are they telling? Soft tissue interposition. What do you mean by interposition? Medial malleolus abduction type. Looks like people that this soft tissue is very easy in these places to get between the fracture fragments and affect the fracture healing, okay? Then bone loss at the time of fracture. At the time of fracture itself, you have lost bone, is it? Like in fracture tibia open type or fracture ulna open type. So where's tibia of this guy? Tibia is somewhere here. So I'm drawing yellow color tibia here. So if the tibia, loss of bone loss at the time of fracture like tibia or ulna. Where is ulna? Ulna is here only, right? So there is bone loss at the time of fracture, is it? Then coming to infection, so open fracture, especially fracture of tibia, etc. Open fracture, we already know this. Infection can happen, osteomyelitis. So acute osteomyelitis, infection can happen, any open fracture for that matter, right? Then moving on down. Damage to the blood supply of the fracture fragments. So basically this is for every fracture, isn't it? The blood supply is damaged. So it could be neck of femur, because neck of femur and all, if you have seen, how is neck of femur? The way neck of femur, see, this is femur. I'm trying to draw a beautiful femur. So you have seen the neck of femur, how the blood vessels are. I'm not correct, but something is there here. So if there's a fracture of neck of femur, there can be damage to blood supply, isn't it? Wait, let me show you the correct femur. Yeah, look at this, guys. Neck of femur, how is the blood supply? You can see the blood vessels here. So here you have the deep femoral artery. Let's use a better color. You have the deep femoral artery. Which color? Okay, some color. Deep femoral artery. From that you have some circumflex, medial circumflex, lateral circumflex, ascending, right? Ascending and transverse and descending. So considering all these arteries here, it's very easy for the blood supply to get affected. So damage to blood supply because of the to this fracture, okay? Fracture of lower third of tibia also they have mentioned here. Pathological fracture, fracture of shaft of femoris, what am I saying? Shaft of femur and shaft of humerus. So again here it is fracture of humerus, but here there is shaft of femur. Pathological fracture, why can it happen, guys? Because osteomyelitis can happen because of tumors, right? Paget's disease or bone cyst or some osteogenesis imperfecta, osteopetrosis, osteoporosis, osteomalacia, rickets. A lot of causes are there. So basically it is the something to do with the fracture itself, okay? Distraction at the fracture site. Where was this? So main thing they are saying is insufficient immobilization, okay. That actually they have put it under the treatment. I would put it under the patient actually. So I would put it here actually. Inadequate immobilization. Very important, isn't it? Otherwise, how will it unite? Causes related to treatment, blame the doctor, inadequate reduction. So you have to do closed reduction, open reduction and all that, right? But you didn't reduce the fracture. What do you mean by reduction of fracture? So basically, however you set the bone, right? So that is what is reduction. Reduction means fix the bone. How will you fix it? So the pieces must be put in close proximity to one another so that the healing can occur. So it is essential, the fracture reduction is essential to ensure that the bone heals properly and there will be return of functionality, etc. So that is what is important, okay? You can blame the doctor if they don't reduce it properly. This is what happens when people go to quacks. You know, you will see a lot of orthopedics cases where they have had a fracture or they have had a fall and they just go to quacks who will fix it with bamboo sticks, etc. without even having reduced the fracture. This is basically not related to allopathy. Mainly the quacks or other people who just splint it or do things, immobilize it without reducing the fracture. So then coming to destruction during treatment. During treatment there is destruction. What do you mean by that? Sounds like there was something which was done to not bring the two parts which have to fuse. They didn't come together. Okay. So we have looked at the causes of non-union related to the patient, old age, etc., malignancies, osteomalacia, the fracture itself, some muscles are pulling the fragments, gravity, soft tissue can get in between, there can be bone loss, there can be infection because of open fracture, or there can be a pathological fracture. Again, that is something related to the patient, I would say. Why is pathologic fracture here? Damage to blood supply. And if you want more marks, just mention everywhere femur, 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 tibia, 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 femur, and some humerus they have mentioned. Patella, I can understand it's pulling the fragments. Okay, you will write femur, tibia, humerus, and pars. Okay, just write everywhere femur, tibia, mostly. Okay. Then coming to this one, you saw treatment itself didn't reduce the thing. Now we have to look at the types of malunion. So you have main two types only they are telling. Atrophic. So we'll go with what the textbook says. Types of non-union. You have atrophic, where there's minimal or no attempt at callus formation. Hypertrophic, where there's lot of callus formation. Which one do you like? I like it. Hypertrophic. It's making so much callus, right? There is callus, but it doesn't bridge the fracture site. Obviously, probably because they didn't even reduce it. So let us say this is the part of the bone. Are you able to see? And this is the other part of bone. They didn't reduce the fracture. So now the callus is forming. Where is the callus forming? Here. So will there be union? No. So hypertrophic callus. There is callus, but it does not bridge the fracture. Okay. So we'll just go with the types from the textbook. Atrophic, hypertrophic. Okay. Now let us go to the sites of non-union. That we already told you here. The sites of non-union, we just write femur, neck of femur especially, scaphoid. Scaphoid is where in your palm, right? Lower third of tibia, ulna, lateral condyle of humerus. These are common sites where you will see non-union. Okay. What happens with this femur, I can tell you, especially neck of femur, when they are telling you this fracture, right? See, if this is neck of femur, not able to draw femur properly. If this is femur and this is neck of femur, imagine if that guy has a horizontal fracture, it's good. See, horizontal fracture, it is good. Not like this, wait. Angle. See, like this, if he has a fracture, it's fine because it will get compressed whenever he's standing or something. So this will get healed. But whenever there is a fracture, which is like, what happened? Now femur vanished. Let's draw the femur again. Let's say the fracture is vertical, then how will it get compressed till? If the neck of the, that's why that angle is very important at which it will. See, if it's fractured like this, it's very difficult, you know, for the, there's no compression for it to heal. So that is why that the angle is there, which will tell at what angle there will be good. The lower the angle, it will heal better, okay. So you will mention all these as the common sites of non-union. Now let's move on to the consequences of non-union. Non-union. What will happen if it doesn't unite? Obviously functionality, right? Non-union. Consequences. Who likes the consequences of non-union? Tell. So what will happen? Consequences. Pain. Yes. Deformity. Abnormal mobility at fracture site. This we already told you. So it can lead to refracture also. Refracture also it can lead to. Okay. If you stress that part. Next, let's go to how you will fix all this. Diagnosis. Non-union diagnosis. We have already covered this anyways. That you will take X-ray. And if any mobility is present at the fracture site or if there is pain, then it can suggest malunion, right? So basically delayed union is a diagnosis in relation to time. So delayed union, you have to check whether it is healing, whether it is uniting, etc. Right? So you'll have to take progressive X-rays, they are saying. Then other things we already told you, pain, mobility in the non-union, right? Increasing deformity, all this will tell you that there is non-union. Look at this. What will you see in the X-ray? You will see that the fracture line is visible. There is little bridging callus. The fracture ends may be rounded, smooth, sclerotic. The medullary cavity may be obliterated. Okay, this is what you'll have to say. What you will see in the fracture. Let's bring back the fracture here. Fracture here, X-ray here. Look at this. This is non-union. Both of these are non-union. This is the atrophic type where you can see very little callus, and here you can see a lot of callus, but it is not helping at all. This is hypertrophic. But anyways, what will you see in non-union? That there is little bridging callus. Callus is there, but the bridging callus is less. Okay, this is what you will see, and then fracture line is visible. So here they are talking about somewhere where there is callus. Okay, it can happen that there is no callus. That can be the atrophic type. The fracture ends may be round, smooth, sclerotic. The medullary cavity is obliterated. So you'll have to sometimes take serial X-rays, guys, because you have to detect some subtle angulation, non-progress of bridging callus, resorption of callus, loosening of screws, bending of the nail or plate. So for all this, you'll have to have a series of X-rays, okay? So because series of X-rays you may need, because how will you note that there is the bending of nail plate, narrow plate, etc., right? Here mobility, they are talking about one thing, that understand that excessive rotation may be the only abnormal mobility in case of an intramedullary rod in situ, right? So excessive rotation may be the only abnormal mobility. Okay, if it is an intramedullary rod that you have put and still it is not uniting. So not only AP view of X-ray, lateral X-ray, you may also need an oblique view which is done under fluoroscopy, okay? Then if you want to check the mobility, you can demonstrate it by stress X-rays, weight bearing X-rays, or a 3D CT scan, okay? Demonstrate mobility, how will you do? To demonstrate mobility, you will need stress X-ray, weight bearing X-ray you will need. And if you want to confirm whether it is a delayed or a non-union, you can use a 3D CT scan. Okay, delayed union or a non-union, if you want to check, you can use a 3D CT scan. Okay, so this is all about the diagnosis, guys. You can do serial X-rays, lateral, AP, oblique. You can check for subtle angulation, non-progress of bridging callus, resorption of callus, loosening of screws, bending of nail plate, etc. You can see whether there is callus or not. How's the fracture line? The fracture ends, are they rounded, smooth, sclerotic? You can see whether the medullary cavity is obliterated. All this in the X-rays you can do. Then you can also do a stress X-ray, weight bearing X-ray to check the mobility, right? Excessive rotation may be the only abnormality in case of a intramedullary rod. Apart from all these things, you can also check for a 3D CT scan to differentiate whether it's a delayed or a non-union. Then coming to all these investigations, leave all these investigations just by clinical features. Can you say it is a non-union? That time you can see that there is increasing deformity or persistent pain or a pain on stressing the fracture. So these are something that you are not using any scan or anything, okay, or an X-ray. So this is what you have seen in diagnosis of non-union. X-rays, 3D CT scan. Okay. Now let's go to the treatment, guys, of non-union. Non-union treatment. How will you treat a non-union? As a summary, you can see the treatment, guys. You can do open reduction. So you'll have to open it up and reduce it. Is it internal fixation? Bone grafting, that means you're taking bone from one place and putting another, is it? Excision of the fragments, you'll remove any fragments that are coming in the way. No treatment if there is no symptoms, that's nice. And then Ilizarov's method, you will do external fixation apparatus for treating malunion. Sorry. Yeah, this is malunion, isn't it? Non-union, sorry, non-union. Okay, we are looking at non-union, so that makes sense. It's external fixation. So what is he saying? his technique is that osteogenesis, that is to make bone, it requires dynamic state. The dynamic state means that the site of osteogenesis requires controlled distraction or controlled compression. It requires either a controlled distraction or a controlled compression. Let's look at this Ilizarov's technique. The fragments can be transported up or down by turning the bolts on the fixator. There's a bone gap here, then the level of bone cut, corticotomy they have done, and they have moved this bone part down, is it? Callus is formed by distraction. Then here there is compression at the fracture, docking, bone formed in the gap. Interesting, they have cut the bone here, is it? Level of bone cut, corticotomy. So basically they are telling that any living tissue can be subjected to growth, it can grow a lot. If it is subjected to constant stretch under biologic conditions, it can grow to any extent. So this is an osteotomy that they have done. It is called as a corticotomy. Basically, he is performing an osteotomy without damaging the periosteal or endosteal blood supply. Okay. That's why it's corticotomy. So this is distraction, is it? And this is compression. And they will do this at the rate of 1 millimeter per day. They use this even to lengthen the limb, guys, if there is shortening, because that can lead to deformity. Even in that case, they are doing Ilizarov technique. But all this they will do only if conventional treatment fails, okay, of non-union. So conventionally what you will do open reduction, because you have to do reduction, right? First of all, reduction, you reduce the fracture, and now they are doing open reduction. Okay. And then internal fixation they will do, bone grafting if required, excision of fragments, no treatment if no symptoms also you can put first itself, right? And then Ilizarov's method, if all this doesn't work, if the conventional treatment for non-union doesn't work, you can do Ilizarov's method. What you should understand here is this Ilizarov's method has some advantages and has some disadvantages also. What do you think the advantages are, guys, and what do you think the disadvantages of these procedures are? You think and see. I have a feeling they are making yet another cut here, so that will become a disadvantage. And there are so many external fixators. How will that person work, right, with all those external fixators? And it's a long duration treatment, isn't it? And there is nerve palsy by pin insertion or traction. So many things they're inserting. There can be joint stiffness, which is caused by transfixation of the soft tissue by the external fixator. Okay, all that we understood. What are the advantages? See, immediate load bearing happens. Immediately this guy can bear the load. Healthy viable bone in place of devascularized bone. Correction of more than one problems by one stage operation. See, finally what I would say is, conventional didn't work, now non-union has happened, you have to fix, you do Ilizarov's, right? Main thing is that only. So guys, if they ask you non-union, I think you will have to elaborate on these more and more. What is this open reduction? All that you will have to explain. What do you mean by this? And from where do you take the bone graft? From iliac crest. That also you learn of. Iliac crest, you can take the bone. Okay. In most cases, you will need to do internal fixation. What is excision of fragments? They are saying lower end of ulna can be excised if the non-union of the fracture of the distal end of the ulna without much loss. So let me say that again. The lower end of the ulna can be excised for non-union of the fracture of the distal end of ulna. Okay, without much loss. In the case of fracture of the neck of femur, okay, the head of femur can be replaced with prosthesis. Okay, so they are removing some fragments. Then what else? Ilizarov's method, basically from USSR he designed a special external fixation apparatus for treating non-union. Okay, so that's it, guys. We have looked at non-union in this video. Let's take a recap. Non-union, basically we are talking about fracture here, because if the union doesn't progress, if there is failure to unite, then you can say it is non-union. A delayed union and non-union you have to differentiate. So basically non-union you can declare only after 6 months. You have to wait, you have to do progressive evaluation of the x-rays to see whether any progress is happening or not. this is and all, you have to use x-rays, etc. Otherwise, if there is mobility at the fracture site or pain at the fracture site, then you can suspect a non-union, isn't it? The causes of non-union there is inadequate immobilization, okay, or there is a old age, so old age osteoporosis, etc. Malignancy is there, or osteomalacia is there, the person doesn't have enough calcium, vitamin D, right? Then coming to other causes of the fracture itself, see, sometimes there can be destruction at the site of fracture, there can be muscles which are pulling the fragments, gravity can be working against you, there can be some soft tissue trapped in between, there can be bone loss at the site of fracture, right? If there is bone loss at the time of fracture, let's say there is one part of the bone here and another part of the bone here and some part in between bone loss has happened, I'm thinking, there is no, it cannot unite, okay? Infection is there, then it will not heal, right? No union will happen. Damage to the blood supply, how can it have a union, right? Pathologic fractures, basically osteoporosis, osteomalacia, osteomyelitis, so many osteo things, hyperparathyroidism, etc. So many things can lead to non-union. Treatment related, they did not even reduce the fracture. Imagine, so many cases we get where we see that the person just went to a quack, they put some splint or bamboo stick and they did not even reduce the fracture. So the two parts are not at all in alignment. So how will the union happen, isn't it? And even during the treatment there could be a distraction. Pulled away, that's what we are saying, pulled away, distraction. Types of non-union, atrophic, hypertrophic. Hypertrophic will have a lot of callus but useless, it is not helping the union. Common sites where non-union happens, always blame the femur, the tibia, right? This much is enough. Then the humerus also if you want. Consequences of the non-union, pain, deformity, abnormal mobility at the fracture site, refracture can happen because of stress. Then we saw that diagnosis, how will you do? Basically you will do x-rays, that to serial x-rays you will do. To check the fracture line, whether the callus is there, whether the fracture end is round, smooth, sclerotic, medullary cavity, has it obliterated. Then you will check whether there is resorption of the callus, loosening of the screws, bending of the nail or plate, right? All this you'll have to do. So you'll have to take AP view, lateral view, oblique view, etc. Mobility also you can check by doing stress X-ray, weight bearing X-ray. Right, sometimes excessive rotation can be the only abnormal mobility if you have put an intramedullary rod. And to differentiate whether it is a delayed union or non-union, you can use a 3D CT scan. Increasing deformity at the fracture site, pain which is persisting, or there is pain on stressing the fracture, all this can indicate that there is non-union. How will you treat it? If there is no symptoms, no treatment, sometimes non-unions do not give rise to any symptoms and there is no need of treatment at all. Like non-union of fracture scaphoid, example for scaphoid, maybe there will be no symptoms, so no need to treat. But otherwise you may need to do internal fixation, very important. You will have to reduce the fracture rate if it has not been reduced, very important. Bone grafting, you can take bone from iliac crest. Excision of fragments you will need to do, especially they said ulna, some parts, or the head of femur, right? Ulna, which part of ulna? Lower end of ulna, head of femur. This has some special conditions, right? Whenever there's neck of femur fracture and that which is having non-union, etc. Ilizarov's method, special external fixation apparatus you have to put. See, it is an external apparatus. How uncomfortable it may be for the patient. Basically, this is working on distraction and compression technique, right? Here they are doing this corticotomy, and they are using these external fixators. That's the word, isn't it? And they are creating callus by distraction, and here there is compression at the fracture. This is docking. Okay, so this is all about non-union. In this video we have looked at non-union of fracture. Bye bye.